Hello, everybody, and welcome to this week's Medicare for All Caucus virtual meeting. My name is Congresswoman Pramila Jayapal, and I'm so proud to represent Washington's 7th Congressional District. I'm also the co-chair of the Congressional Progressive Caucus, which has almost 100 members of the Democratic caucus within our Progressive Caucus. And of course, I'm the lead sponsor, along with Congresswoman Debbie Dingell, of the Medicare for All Act of 2019. And we are very excited to be here with other members of the Medicare for All Caucus, which Congresswoman Dingell and I co-founded, really to help our own members educate themselves on all the information that's out there that will help us move forward universal health care for everyone. And today we have a fantastic panel of guests and a number of people that are tuning in. And so for all of our members who have joined this meeting today, we're looking forward to your questions during the question and answer portion. You'll be able to ask your questions and give any of your thoughts to our experts and to the folks that are tuning in after we hear brief presentations from each of the panelists. We are all here to discuss the public health crises that our country is facing. For the past several months, we've been fighting the COVID-19 pandemic. The very first case of COVID-19 was diagnosed here in my home state of Washington on January 21st. Today, COVID-19 has already claimed more than 100,000 American lives, more American lives lost than during 2 decades of the Vietnam War, and now surpassing the number of American lives lost during World War I. Almost 43 million Americans have filed for unemployment in just 11 weeks, and at least 27 million workers have lost their health care simply because they lost their job during this crisis, a consequence of a cruel for-profit healthcare system that continues to tie insurance to employment. But we must be very clear that the effects of this crisis, disproportionately felt by Black, Brown, and immigrant communities, are tied to long-standing violence and systemic racism that these very same communities experience. In the past 2 weeks, we have all watched with heartbreak as protests have spread across the country following the murder of George Floyd by Minneapolis police. But the anger that Americans are feeling right now is not only about the horrific murders of George Floyd or Breonna Taylor or Ahmaud Arbery or so many others. It is anger that has understandably emerged from generations of racism, oppression, and broken promises in every part of American society, including a healthcare system that has failed all of us, and especially our most vulnerable. Black and Brown Americans are much more likely to be uninsured, more likely to die during childbirth as a maternal and infant mortality crisis ravages our country, and they've got a lower life expectancy overall. Black Americans have nearly 3 times the odds of being hospitalized as white Americans, and they're nearly 4 times more likely to die from COVID-19. We have to be very clear. This isn't because Black and Brown Americans are somehow just not taking care of themselves. It's because we have not provided a healthcare system that allows people to take care of themselves when they're sick. We have not provided insurance for people, and we have not provided a cost-effective means for people to think first about their health and not anything else. COVID-19 has exposed and widened the cracks in our healthcare system, the cracks that allow 80 million people, or nearly half of all adults under 65, to be uninsured or underinsured in this country even before the first case of COVID-19 arrived in America. The cracks that put 500,000 Americans into medical bankruptcy each year. So as the lead sponsor of the House Medicare for All Act with Congresswoman Dingell, I've been struck once again by how important it is that we make healthcare a human right for everyone. Medicare for All means that every person in this country should have guaranteed healthcare, regardless of race, gender, sexual orientation, gender identity, employment, or immigration status. And we don't just mean that everyone should have some level of healthcare coverage. We actually mean that we would have a comprehensive set of benefits for everyone. That means dental and vision, mental health, reproductive health, and long-term support services. We have to do more to ensure health security for millions of Americans. That's why Congressman Joe Kennedy and I introduced the Medicare Crisis Program Act, as well as the Healthcare Emergency Guarantee Act that I introduced with Senator Sanders, so that we can enable everyone during this crisis, including those who are uninsured and underinsured, to get the healthcare that they need through reliable public health insurance programs. We need to come together to minimize the impact of this pandemic on our health system, to save lives and to prevent further outbreaks. And then we have to take bold action to ensure that our healthcare system is one that guarantees everyone the care they need when they need it, and that our public health responses are strengthened during times of calm and in times of crisis. So we are fighting because we believe that universal health care in the form of Medicare for all is the way to achieve health justice and security for all. We have to recognize that health justice is inextricably intertwined with racial justice, economic justice, and social justice. So I want to thank everyone for being here. I look forward to hearing from our other speakers, our other members of Congress, and then taking your thoughts and questions. And now I'd like to introduce my dear friend, my collaborator, my co-sponsor, co-lead sponsor of the Medicare for All Act, Congresswoman Debbie Dingell.
Thank you, Pramila. It's really good to be with you today. And I want to thank all of our colleagues who have joined us on whatever we're calling it, this virtual talking about an issue that needs to be talked about, and COVID has really shined a light on the needs, and to all the advocates who've come together on this virtual hearing today. We're here at a critical moment. Right now, our nation's still in a public health emergency from COVID-19, which is our main focus for today's event. But as our nation listens, learns, and acts on racial disparities, we cannot turn away from the very serious health disparities that exist for African Americans. In my own state, 14% of the population is African American, and more than 43% of the deaths have been in the African American community. These disparities have put our Black neighbors and our friends at greater risk for COVID-19. It's connected, it's all important, and we must address it. We're going to get through this together, but this crisis has laid bare the cracks and the flaws in our for-profit healthcare system. We spend twice as much per person compared to other countries that have universal healthcare systems like Medicare for all, but we still have 27 million people without insurance. And we have worse outcomes, including low life expectancy and higher infant mortality rates. The current system has resulted in disparities in this country that mean how long you're expected to live for is determined by your zip code. Before the COVID-19 crisis, I've had African American women in Michigan tell me there's no point in getting a mammogram because even if they find cancer, they can't afford the treatment if they're diagnosed. In Michigan, 37% of Michigan's uninsured are minorities. This is clearly a broken system and disproportionately affects minorities and low-income working families. It's not acceptable. Medicare for all is the answer. People should not have to be worried about whether they have insurance or not. Lack of widespread testing, the lack of access for so many, and the financial situation are facing are all making the case for why we need to transition to a Medicare for all system. It would be more equitable, more fair, and more responsive to future crises like the one we are facing. We are also, as I started to talk about before, the only industrialized nation in the world that doesn't guarantee all of its citizens health care. And I was just on Fox talking about this, and I said, it's not, for me, it's a moral issue, but it's also an economic issue. And people need to understand that. When you're competing in a global marketplace, those healthcare costs are part of what our businesses pay. And they're always fighting about it. We should just have a healthcare system that takes care of everybody, and there shouldn't be fights. Everybody should have that excess. It must change, not just because, as I just said, it's the moral thing to do, because tying people to employers for healthcare is holding us back on innovation and entrepreneurship. Right now, millions of people have lost their jobs because of COVID-19, and their healthcare has come with their employment. Alternatives are unaffordable for them. This pandemic is highlighting all of the immense flaws in our system, and people are being left hanging out there to dry because of it. If we want to stay competitive with our peer countries, we have to transition to a better, more efficient system. We come together today in support of universal health care and Medicare for all. This issue is so important, and I have to tell you, it's really personal for me, which is why I am very passionate about the issue, just in case you can't tell. But I know that everybody out there listening to me, I know Pramila is, the two of us get going some nights, and our colleagues just like, give us space, give us distance. It's personal because every day I hear the heart-wrenching stories of nurses who are on the front lines, who don't have the PPE equipment that they need to keep themselves safe. I've had a nurse called me writing her will and making me promise that if she died, I'd make sure a child didn't go into foster care. They're wondering if they lose their job because they got infected at work, what are they going to do? I've heard from the workers who lost their jobs and their health insurance that comes along with it, and they can't afford the COBRA coverage or other alternatives. That's what Pramila was talking about before. I cannot think of a better time to make the push for single payer for healthcare, for access to healthcare, than right now, so that it isn't tied to your job, while we are looking at the significant number of unemployed that we have. Too many people are fighting for their lives, their families' lives right now, and they are suffering, and we need to fight for them. This is personal to me because without protections for pre-existing conditions, the mother of a child with juvenile diabetes worries about their future or any future her child might have. I was with John Dingell on one of his last doctor appointments when a mother of a diabetic child came up to us and asked that question. I'm fighting for her. It's personal, quite frankly, because of my own family's history with Medicare for all and the fight for universal coverage. When John entered the Congress in 1955, he began introducing a single payer bill every year he was in the Congress to keep this issue alive. That fight earned a significant victory in 1965 when we passed Medicare and Medicaid, and they were signed into law. And it wouldn't have happened if it hadn't started with his father. I keep up the fight for them, both of them. Actually, it's the deathbed promise I made to him. 75 years ago, in 1945, my father-in-law introduced the first universal health care bill, the Wagner-Murray-Dingell bill, in the Congress, and I'm fighting for them. Single-payer ideas have been around for 3/4 of a century. It's not a political fad. It's a cause that my family and others have been championing for generations. And it's what we're going to finally deliver for the American people. And just for the record, my father-in-law was called a socialist, a communist, had a cross burnt on his lawn because he fought for this. But I'll tell you something else. He was also one of the authors of Social Security. These stories matter. And as you all do impressive work on the ground, we can't lose sight of those we are helping, the lives we are saving with access to care, and the valuable hard-earned money we are saving working families and seniors. In the United States of America, healthcare is a right. It's not a privilege. Every person in this country has a right to quality healthcare, period. Medicare for All promises to streamline and our fragmented healthcare system and expand and improve coverage for every American. Ensuring coverage for all Americans would improve the efficiency for providers who would not have to manage multiple insurance plans. It would let doctors and nurses focus on actually delivering healthcare instead of managing paperwork from countless insurance plans. It would reduce administrative costs, which are taking away money that we need to be putting into the system. And it would give working families greater certainty and peace of mind that they'll still have coverage if they lose their job or if they're laid off the way they have been by COVID. When you go to the doctor, you shouldn't have to worry about how you're going to pay for it. You shouldn't have to worry about what the diagnosis is going to be, so that if you can't afford it, what it's going to do to your bank account. In no other industrialized country in the world does that fear exist. Too many families, too many young people, too many seniors and caregivers are too often desperate and stressed, not knowing where to turn. And it's time for a change in our system. No one person will get this done alone. It happens when we all join together.
Something happening?
So that's why this webinar is so important. We can all come together to act now during this time of crisis. Thank you all for being a part of this movement and for letting me speak to you today.
Thank you so much, Congresswoman Dingell. Again, for those of you who have joined us, and I'm watching the numbers on the Zoom call, it's amazing. We have almost, let's see, it looks like 370 people that have joined us from around the country, more that are watching on Facebook Live. This is a meeting, a virtual meeting that's been called by the Medicare for All Caucus, which Congresswoman Dingell and I co-founded and now lead in the Congress. We've been joined by a number of our colleagues who are members of Congress as well, and we welcome them. And now we're going to go to 3 panels of experts. I want to say that none of this work that we were able to achieve in this Congress, including the first 4 hearings on Medicare for All that have ever been held in the House of Representatives, none of that would have been possible without the organizing across the country. So I welcome everyone that is here on the Zoom call listening, and our panelists who have been so important to our movement. So our 3 panels will be, the first panel will speak to the overall health system here in the US and in Canada. And then we will have a labor and business panel, and finally an on the ground panel. So let me introduce our first panel. We have with us Eagan Kemp, who is a health policy expert who formerly worked as senior policy analyst at the US Government Accountability Office and is now a health policy advocate for the nonprofit consumer advocacy organization Public Citizen, that has been such a key partner with us, both in crafting the Medicare for All bill and in helping us to advocate for it across the country. We also have with us Professor Karen Palmer, who is an adjunct professor at Simon Fraser University and former officer at the World Health Organization with nearly 3 decades of experience in health policy research, government, and public health. So let me turn it over to the 2 of you, Eagan and Professor Palmer, for your initial comments, and then Congresswoman Dingell will introduce our second panel.
Thanks so much, Representative Jayapal and Dingell, for convening this important panel at this crucial time, and for kicking off this discussion with such inspiring words that highlight how far we've come, but how far we still need to go. As Representative Jayapal mentioned, my name is Eagan Kemp, and I'm the healthcare policy advocate for Public Citizen. And as you all know, we're experiencing profound and devastating crises that are rending the cracks of our broken healthcare system, COVID-19 and the legacy of systemic racism. I will keep my remarks brief, but I want to point out one key factor underlying challenges and opportunities being discussed by all the fantastic speakers today: corporate power and profit. Profit determines who gets care and who has to go without. I'll touch very briefly on how that affects the insurance system, hospitals, and then drugs and vaccines. When I talk about the health insurance system being broken, I'm taking the perspective of patients, their families, and working people across this country. Can you imagine a more absurd system than one where tens of millions of Americans lose the jobs upon which their health insurance depends in the middle of a historic pandemic? Over 150 million Americans get their coverage through their jobs right now, meaning any of them could be at risk of losing coverage as we deal with waves of COVID-19. We've heard horror stories from journalists and our own members of people falling through the cracks right now, including folks, near term in pregnancy, losing their insurance and having to figure out where coverage they can get and what doctor they can go and see. But from the perspective of insurers, the system works perfectly. They take your money, your family's money, your employer's money, and they use every sneaky trick in the book to stop you from getting the care they need. The biggest insurance lobby in the country, AHIP, is in the middle of a PR blitz trying to make the case that they're going above and beyond to ensure enrollees can get COVID-19 testing and treatment. But when we looked at these supposed benefits for the top 25 insurers, what do you think we found? Empty or confusing promises of care and even plans that were failing to meet the basic standards set by Congress for COVID-19 testing. The gaps were big enough to drive a semi-truck through. Under Medicare for All, you wouldn't have to worry about such confusion because you would be covered at the hospital or provider of your choice for any medically necessary testing, treatment, or prevention. When it comes to hospitals, the story is similar. Hospitals are increasingly run at the behest of Wall Street vultures who buy up hospitals, strip them, and sell them for parts, regardless of how many people it hurts. The situation is far too common in this country, especially for rural hospitals and hospitals that treat a disproportionate amount of people without insurance who are experiencing poverty or homelessness. These crucial hospitals are at risk of closure in large part because the healthcare system doesn't reward actually providing health. Under Medicare for All, hospitals we put on a firm footing through comprehensive and consistent funding that would ensure that hospitals have the money they need to keep their doors open and to treat the health needs of their communities. Representatives Jayapal and Dingell had the foresight to include specific provisions in their Medicare for All legislation that would allow the federal government to be nimble in times of crisis like COVID-19 and also to address long-standing other emergencies, such as addressing the disaster that is Black maternal mortality in this country. As with insurers, Medicare for All would mean peace of mind when it comes to figuring out what providers you can see. And finally, when it comes to drug prices, we all know that the American healthcare system is failing us. At this moment, the federal government is pouring billions of dollars into COVID research and development. For all of that investment, it is incumbent upon the government to ensure that these publicly supported COVID-19 treatment and vaccine technologies are treated as the public goods that they are. The federal government must promote increased manufacturing capacity throughout the world to meet the unprecedented demand and to promote innovation through open science and collaboration. It's long past time that the federal government ensured a fair public return on public investment in pharmaceutical research to ensure products are priced at a fair level that it facilitates access. The COVID-19 pandemic has laid bare just how difficult it is for Americans to get the care that they need, to be able to access the drugs they need, and that applies to vaccines as well. And importantly for this discussion, Medicare for All would bring the full negotiating power of the federal government on behalf of the American people to ensure they can finally get the access to the drugs and other treatments that they need without the barriers that they face right now. Thanks again for having me on the panel, and happy to take any questions.
Shall I start? Thanks. So thank you for inviting me to comment today. In the presence of Representatives Jayapal and Dingell, I feel like you have all the expertise you need about single-payer healthcare, but I can at least update you on the Canadian experience during this pandemic. So I'm in British Columbia, so I'm just 30 minutes north of the US border from Washington State. I lived in the States for 22 years, so I'm pretty familiar with the context there. As in the US and everywhere, of course, this pandemic has been a frightening and exhausting time for everyone. Like in the US, starting in mid-March, we had strong physical distancing in effect. Many businesses closed except those that were considered essential services. And so things are beginning to reopen now in most provinces, carefully and cautiously, with plans in each province for how that will unfold safely. In British Columbia, we have a 4-phased reopening plan that began May 19th. And yesterday was the 6th day in a row in this province with no new cases. But across Canada, yesterday there were 410 new cases, with most of them in Ontario and Quebec. We're not quite out of the woods yet in Canada, but we're certainly moving in the right direction. I think we did a good job of preparing for the potential surge. Among the 37 million people living in Canada, as of yesterday, 7,395 have died from COVID, including 167 here in British Columbia. So that's compared to about 115,000 in the United States. So that's 21 deaths per 100,000 in Canada compared to 34 deaths per 100,000 in the US. 95% of our deaths in Canada have been in those aged 65 and older, and of those 79% were in long-term care homes. But our healthcare system wasn't overwhelmed. One of the biggest strengths of our response has been through our healthcare system. People have not delayed care because they're worried about the cost of care. So if you get sick in Canada or you think you have COVID, nobody in Canada lacks access to hospitals or physician care. For any care that you get from a physician or hospital, you will have no copays, no deductibles, no coinsurance, because those things just don't exist here. So as always in Canada, care is free at the point of service. There's no cost sharing at the point of care. In response to COVID, some provinces, including British Columbia and Ontario, have actually expanded coverage to those who would not otherwise be eligible, such as the temporary foreign workers who are here with a permit that allows them to be here for less than 6 months, like those that are here to help plant our crops in the fields, because protecting them too protects everyone. So in the midst of this pandemic, people aren't also worrying about how they will pay healthcare bills because they don't have any. So they are more likely to seek care sooner. In terms of our hospitals, because our hospitals are all publicly funded, there's an impetus for hospitals to work together. There has been coordination within each province to liberate bed space, with everyone planning together across a whole region to make sure that if the surge had hit hard, we could manage it. People are thinking across sectors to take care of their communities because the single payer system enables that kind of cooperation. Our governments and healthcare leaders have generally done a good job of supporting healthcare providers and communities with everything from a nearly overnight shift to virtual care so people could continue to connect with their usual healthcare providers, to sourcing more PPE, which has been a problem here too, to setting up testing sites, to helping hospitals increase critical care capacity to support public health in terms of contact tracing, to closing our border with the United States, which was initially a main source of our cases in Canada. Last week, we learned that viral strains traced to Washington State have now been linked to a large number of cases in Vancouver, particularly in our long-term care homes. So it turns out that our health depends to some extent on your health. Like everywhere else, COVID has had a huge impact on our economy and on employment, but very quickly the federal government stepped up with $2,000 per month for up to 4 months for anyone who lost work because of COVID. So to apply for what's called the Canadian Emergency Response Benefit takes about 2 minutes, and the money is directly deposited into your account, usually by the next day or the day after. The federal government also gave a 75% wage subsidy to employers who'd lost income to help them keep employees on payroll. So they were able to rehire workers that they'd laid off. And so now they're in a better position to resume normal operations. But unlike in the United States, people who are laid off in Canada don't face the worry of losing their health insurance because hospital and physician care is not linked to employment. So I'll just conclude by saying that there are many lessons from COVID for all of us around the world. If there was ever a case to be made that the world needs to go bigger on public health, it's now. That's true for every country in the world, including Canada. Thank you.
Thank you, Professor Palmer. We're going to try to keep this moving because we want to get to the members for questions, but you guys are both great. I'm going to do the next panel, which is the labor business panel. I want to introduce Marty Garza, who's the health director of the International Association of Machinists and Aerospace Workers, one of the largest and most diverse unions in America, with over 600,000 members. And Aaron Seyedian, I hope I didn't blow it too much, owner of Well-Paid Maids, a living wage company that is changing the service industry by providing just compensation, starting with $17 an hour pay, and they start with insurance right away. Marty, why don't you start?
Thank you. So I'm with the Machinists Union, and for us in labor, we're largely an industrial union. I'm the director of our healthcare division, which is 15,000 plus healthcare workers across America. The COVID-19 pandemic has really been a wake-up call for the unsustainable nature of healthcare benefits tied to employment. And it's really sort of demonstrated the lack of resilience and precariousness of such a model in our interconnected global economy. At a time when a significant portion of labor's members are being laid off from their jobs and stress is being put on working men and women to figure out how they're going to make rent, how they're going to make a mortgage, how they're going to pay bills. On top of that, they now have to worry about how are they going to get their health care. And it's really a little bit of a kick in the teeth for labor because, in the collective bargaining process in our country, we defer gains in wages and retirements and other benefits to sort of hold the line on the ever-increasing skyrocketing cost of healthcare premiums. And now many of our members are in a position where all those deferred wages and benefits are just inaccessible and useless to them because they are not able to access their health care. So I think for many of us in the labor movement, this is a little bit of a wake-up call that even in what's traditionally been sort of good, strong, middle-class union jobs, the model of tying healthcare to employment is just not sustainable. It doesn't matter how good your collective bargaining agreement is, doesn't matter how resilient your industry is to globalization or outsourcing or any of these other stresses on the sectors in the American economy. The pandemic has really just demonstrated again the weakness and the precariousness. And so we are at an inflection point, I think, in the labor movement where working men and women who previously thought of Medicare for all as pie in the sky or unrealistic are suddenly reevaluating that in a new light in this current reality. And it behooves us in labor to work with our elected champions like Representative Jayapal and Representative Dingell and the rest of the members of Congress to sort of stand up and fight to guarantee healthcare as a human right, regardless of whether or not people are employed in whatever sector in our economy. Thank you again for allowing us to sort of give our voice to this very, very important issue in facing American families across our country.
Hello?
Aaron, you should.
Hi. Yeah, hi. I'm Aaron Seyedian. Thank you, Representatives Jayapal and Dingell for having me on this panel today. As Representative Dingell mentioned, I'm the owner of Well-Paid Maids. We're a living wage home cleaning company in the Washington, D.C. area. We have 15 employees, and as you can tell from the intro and our name, hopefully, we start folks off at $17 an hour, what we think is a living wage for our area, and offer a full benefits package, which in normal times is pretty good. We offer good insurance. We offer a zero deductible platinum level plan. It's the same plan that I used to have when I worked in consulting. But obviously we're not in normal times right now. And so it doesn't really matter how good our insurance plan is. We find ourselves in a pretty dicey situation. So due to the pandemic, we've been shut down since mid-March. We shut down voluntarily out of the interest of staff safety and customer safety. And we're still shut down because I don't see the conditions operating that would allow us to go back out there and serve customers again and do it safely. A typical cleaner of ours is going to go into 40 or 50 homes a month. It's just not a safe situation. So we're going to stay closed. And employees have been kind of powering through it with a mix of unemployment and the PPP program. So our last PPP kind of tranche was exhausted through this last payroll that we just conducted. And of course, that also means that our last support for health insurance premiums is now gone. And so, you can kind of muddle through with UI, but health insurance premiums are definitely another story. So in March, I paid for my staff's premiums out of pocket. In April and May, they were covered through the PPP program. But now we're back to this unsustainable situation where, I'm left with this really repugnant, impossible choice, which is either reopen in an environment that I think is unsafe, risk my customer health, risk my staff health, just so we can generate the revenue to cover our insurance premiums, or stay closed, which I believe is the right thing to do, and eventually, at some point, throw my employees off their healthcare insurance, during a pandemic. So, in my view, those are both immoral choices. Those are both impossible choices. I don't like either option. I'm gonna try to keep paying for premiums as long as I can, through my own funds, as well as we have a really devoted customer base, some of whom are continuing to pay their bills so that, we can help defray the cost of that. But that's not how this should be managed in anything that we would call a sane and rational and healthy country, right? So it's obviously a ridiculous situation, obviously not the way we should be going about this, and obviously immoral from my perspective. The impact on my staff when they lose their insurance is going to be horrendous. Some people talk about COBRA like it's a real option. It's not a real option. It's a fiction. Because we have good insurance, my staff especially can't afford to continue their premiums. Some folks might be able to go on Medicaid. Not everybody. People will not qualify for different reasons. And based on our experience with unemployment, where I've had some workers that couldn't get on unemployment insurance for weeks and weeks and weeks, we know that even if folks are able to get on Medicaid, there's going to be a really significant gap in coverage for them, which of course is, the most dangerous thing to contemplate during a health crisis like this. So, in closing, I just want to say it's not my first rodeo with the absurdity of this employer-sponsored healthcare system. Look, when you're just a regular Joe, before I owned a business, right, I knew that our health insurance system was horrible, right? We all know it sucks. But when you own a business and you're responsible for, in my case, 15 people, not only do you see it at the bird's eye level, and so you can see all the bureaucratic machinations behind it that make absolutely no sense, you also see it in aggregate. So I also see in a really magnified way how all these how all these major crises kind of percolate out of this really failed, really corrupt for-profit system. And so in not even 3 years of being open, just to share with you a few examples, I've had an employee who moved, wanted to work from home in another state to follow her husband to his job where he was hired. And she lost her healthcare insurance through us for a significant amount of time because we had a regional plan that didn't cover the state that she was moving to. I've had an employee who's been with us for over 2 years, and even though he can get better insurance for less through my company, he has decided to stay on insurance that he selected years ago and pays for completely out of pocket because he's responsible for the long-term care of his elderly parents. And he's so nervous to, move that Jenga block and destroy the whole thing and have an interruption to their care that he's willing to, pay more for worse insurance for fear of disrupting anything and putting them in danger. And then the worst example of this horrible, immoral system is I had an employee who she lost her job with us through no fault of her own. Not that should matter either way, but in any case, we closed down a branch that wasn't successful. She was a great employee. We wish we could have kept her and kept operating in that city. 2 days after she started her new job with someone else, she found out she had breast cancer. Insurance at her new job didn't start for 3 months. And she, reaches out to me, Aaron, what do I do? Am I still covered? And in that example, and in so many other examples, all I can say is, I'm sorry that things are the way they are. I know that it's insane. I wish we could help you better. That's not a good response. It's not a good response from me. It's not a good response from, our public policy. And I'm really hopeful that, with leadership like Representative Jayapal's and Dingell's, that, we can take this crisis and use it not just to shore up this really terrible system, but create something new, because I think people are starting to realize that, we're the sane ones, we're the rational ones. What's pie in the sky is the idea that this for-profit system can continue. So that's my perspective as a business owner, and thank you for having me.
Thank you so much, Aaron and Marty. I think both of you are highlighting the work that has happened with our coalition partners in labor and business, because this is something that affects all of us. And I think that you've both spoken powerfully to how that's changed. I want to introduce our last on the ground panel. And again, we have many members of Congress on the call that I want to make sure we get to for questions. So our last panel, and I would just ask you to keep your comments as short as possible so we can get to questions. Barbara DiPietro is the policy director for the National Healthcare for the Homeless Council, a network of over 300 organizations which provides healthcare and social services to 1 million unhoused individuals each year. Jean Ross is the president of the National Nurses United, the largest nurses union in the United States, a huge champion, co-conspirator, collaborator with us as we developed the Medicare for All bill, who also has decades of frontline experience herself as a former nurse. And then Dr. Sanjeev Sriram, who is a senior advisor at Social Security Works, co-founder of Masks for America, a nonprofit providing PPE to frontline workers, and founder of the All Means All campaign, which seeks to make racial equity a cornerstone of the Medicare for All movement. And again, a wonderful collaborator with us as we've been moving the Medicare for All movement forward. So let's start with Barbara.
Thank you so much. I appreciate it. And thank you for having us in this discussion and holding this meeting. As you mentioned, the National Healthcare for the Homeless Council, we provide training and technical assistance, research and policy analysis to support 300 healthcare for the homeless programs nationally, and that collectively serve 1 million patients, as you had said. We are federally qualified health centers that provide primary care, behavioral health, case management, and our model of care emphasizes outreach and low barrier access to care. It's important to appreciate, though, that on any given day, there's 500,000 people experiencing homelessness in this country. And over the course of the year, 1.5 million people will cycle in and out of our shelters. Homelessness isn't just a housing crisis. It's also a healthcare crisis. And this crisis is disproportionately impacting people of color, because African Americans, is one example, are 13% of the general population, but they are 40% of the homeless population. So let's appreciate what COVID-19 means for us as providers to patients experiencing homelessness. This is a high-risk group, disproportionate levels of chronic and acute medical conditions, and an aging population. And this combines the 2 key risk factors for contracting the disease. Also, what does it mean to stay home, wash your hands, socially distance when you live in a crowded shelter or on the street in an encampment? We're talking a lot about nursing homes and jails in this country, but we're not talking about homeless shelters. Our patients are seeing significant upheaval right now. Shelters are either closed or they're half capacity. Restaurants have largely been closed. Soup kitchens are overwhelmed. Libraries and other spaces where people get services are closed. Our patients are scared of getting infected, and they are well aware that they have limited ways to protect themselves. As providers, we are also experiencing major challenges. Our capacity is down, and some of our clinics have had to close or curtail services. We are desperately concerned about the fate of layoffs or furloughs of our staff because we can't keep revenue going. We've pivoted directly to try to do telehealth, conduct testing where possible, but truly we are worried about the impact of untreated medical conditions and increases in death and illness among our patients just because of disconnection from care. So when we talk about, from our perspective as providers on the ground, how would our nation's response to COVID-19 look different if we had a Medicare for All system? And I would assert 5 different ways. One, I would say we would have better baseline health. Those who are very poor or those who are homeless likely would experience better health status because of single payers' emphasis on preventive care, easier access and affordability. Second, I would assert that we would have fewer people experiencing homelessness in this country because poor health is a major cause of homelessness. And while a single payer system can't solve all of our country's problems, we absolutely can't ignore the direct and indirect benefits that would prevent poor outcomes like homelessness. Third, we can offer more patient care if we eliminate all the administrative inefficiencies that cause us to have to hire teams of people to sort through different insurance plans, drug formularies, and a constantly shifting insurance status. It's incredibly inefficient, and that time can be better spent actually delivering care in the exam room or doing a telehealth visit. Fourth, a single payer system would allow us to do better public health. It would allow us as providers to respond faster to the needs of homeless populations during this pandemic because we'd have better access to health information and be better able to respond to community needs in a more timely manner. And finally, I would argue we would have fewer healthcare disparities because your health coverage wouldn't depend on whether or where you worked, where you lived, how much you earned, how old you were, or any of these factors. We would experience fewer racial and ethnic and geographic diversities in our healthcare system. And so in conclusion, I know I just have a brief time, but COVID has shown that my health is specifically dependent on your health and vice versa. A single payer system reflects the reality that we are all in this together. But we can't talk about true healthcare reform without talking about poverty, racism, and injustice. And as we all move forward, as you move forward in Congress to advance single payer, we ask that you keep these issues at the center of the discussion. I know I've been brief. I've touched on a number of things. I'm happy to answer any questions or speak further to any of these issues. I so appreciate you holding this meeting today and including our perspectives in the discussion. Thank you.
Thank you so much. Jean Ross. You're muted, Jean.
There, is that better?
Yep, we hear you now.
Thank you. Good morning and thank you, Chairwoman Jayapal, Chairwoman Dingell, and the members of the Medicare for All Caucus, and thank you for giving me this opportunity to speak with you this morning. My name is Jean Ross. I've been a registered nurse in Minnesota for over 45 years. I serve as president of National Nurses United, the largest union of registered nurses in the United States. During the COVID-19 pandemic, nurses have been risking their lives to care for patients among great challenges from the novel coronavirus itself, but also from a for-profit healthcare system industry that has been privatizing and prioritizing protecting hospital bottom lines over the health and safety of patients and caregivers. This pandemic has laid bare the deep failure of our fractured health system. And in doing so, it makes a strong case for transitioning to Medicare for All. I'd like to talk to you through a few of the key challenges we're facing at the bedside during the pandemic and explain how single payer would address these challenges. For 4 months, nurses across the country have been caring for patients during the pandemic without the personal protective equipment that we need to do our jobs, to do it safely. Despite all of the discussion and media attention surrounding the lack of PPE, we still are not getting the correct protection. As a result, nurses and healthcare workers are constantly being put in risk of exposure to COVID-19, and it's unnecessary. Many have become sick, some have died. Nurses are living with the constant fear of bringing the virus home to their families. Many are quarantining away from their children, away from their spouses for months in order to protect them. As of today, more than 134 registered nurses have died. Tens of thousands have become infected. There are major reasons, 3, why we haven't had the PPE we need. Number 1, hospitals have stocks of PPE, but they've refused to give it to us because they're worried about a shortage at a later time and they don't want to purchase additional supplies. 2, the federal and state government efforts to distribute PPE from stockpiles have been ineffective, with frontline workers left wondering where the PPE stock went to. 3, there is insufficient production and purchasing of PPE at the levels we need to protect healthcare workers during this pandemic. It didn't have to be this way. Our hospitals should have been prepared with stockpiles of protective equipment, and the system as a whole should have a strong medical supply chain coordination mechanism. Instead, hospitals operate on this just-in-time model. In this, they only purchase necessary equipment when it's needed, and this reduces their expenses and increases their profit. The pandemic puts in stark relief the life and death consequences when hospitals are allowed to run like factory assembly lines. Our patients are not car parts. Under a single-payer system, profit would no longer be an incentive. The Medicare for All Act of 2019 would establish global budgets to finance hospitals. And within those budgets, the Medicare program could ensure that hospitals are purchasing adequate supplies of PPE to prepare for infectious diseases. The new system would also be able to guard against a raft of closures of our safety net hospitals in both urban and rural areas. This is what we're seeing now, closures that are increasing during the pandemic. The lack of transparency and the fractured nature of our health system today has hindered distribution efforts of PPE stock to hospitals, especially the ones that need it most. It's worth noting that this fractured system has also been a major challenge to ensuring the dramatic scale of testing availability. Under Medicare for All, the single-payer system would allow for increased transparency regarding PPE through robust reporting mechanisms and a more efficient and effective distribution mechanism for necessary medical supplies, even in the midst of a pandemic. Last, it would make a major investment in coordinated public health programs. These are desperately needed to confront pandemics such as COVID-19. COVID-19 has demanded a coordinated healthcare response. Our country has failed to deliver one. Services such as testing, treatment, and hopefully a vaccine will need to spread faster than the virus. And the only way to deliver healthcare service in an efficient, methodical way is through a single-payer Medicare for All plan. Thank you.
Thank you so much. Dr. Sriram. I think you're unmuted.
Okay. Hi. Can you hear me?
Yes.
Okay. Hi. So we are all facing COVID-19, but we are not all at equal risk. Communities of color, especially Black and Latinx people, are dying at staggering rates of this pandemic. As of late April in Chicago, Black people make up 30% of the population in that city, but account for over 70% of COVID-19 deaths. In New York City, Latinx patients have a death rate of 22.8 per 1,000, higher than any other group. The eyes of the world have been on Minnesota for the past couple of weeks, as they should be. In Minnesota, Black people are 6% of the population, but 28% of the confirmed COVID-19 case. The pandemic is exposing a long-standing and long-ignored truth. People of color in America have been suffering and dying from health disparities, and the status quo of our healthcare system is complicit in those injustices. Medicare for All is the most powerful health policy we can pass to build racial equity in America. At All Means All, our goal is to make racial equity a cornerstone of Medicare for All. Prior to the pandemic, we found 59% of America's uninsured were people of color. That statistic has most likely worsened. Economic downturns disproportionately devastate minority groups. At All Means All, we have fact sheets about racial disparities in coverage for every congressional district across the country. I brought up Minnesota earlier, and I believe that state demonstrates the urgency of Medicare for All for racial justice. In Minnesota, people of color make up only 21% of the general population, but they are 44% of the uninsured. This is despite the fact that 90% of Minnesota's uninsured were working pre-pandemic. Our system unjustly ties one's employment and financial resources to one's healthcare, reinforcing the racism of income inequality. But for healthcare to be a true human right, the only eligibility one should require is one's humanity. But that's not what we have right now. People of color face labyrinths of eligibility. They frequently work at low-paying jobs with no benefits. And if work is going to be essential, then workers must not be treated like they're Medicare for All ends at income inequality and hinders minority from health. Just as importantly, Medicare end program because they supposedly earn too much. Even when they qualify for subsidized private insurance on the ACA exchanges, people of color postpone or avoid necessary medical care because they are rightfully worried about whether they can afford all the copays and deductibles. Now more than ever, we need coverage to be mobile. Moving from state to state or from job to job should not mean you lose your health care, especially during severe recessions when such moves are necessary for financial survival. With Medicare for All, the coverage moves with you over the course of your life. That mobility of coverage is critical for lifting the health of people of color. The universality, the financial peace of mind, and the mobility of Medicare for All are not the only reasons why the policy is critical for racial justice. With Medicare for All, we would have more just, equitable funding for all of our hospitals and clinics. Equitable, reliable funding for hospitals is an aspect of Medicare for All that would not only save people of color during this COVID-19 pandemic, but would also be a means of reducing and even eliminating a range of minority health disparities from maternal mortality to asthma attacks to cancer screening and treatment. Many of you have probably heard America will be a majority minority country by 2040, but I disagree. We are already there. In 2018, people of color were the majority of the population in Hawaii, California, Nevada, New Mexico, Texas, DC, and Puerto Rico. In my home state of Maryland, we're 49.5% of the population. Since 2011, the underage 10 population has been majority people of color in all the states that I mentioned, plus New York, New Jersey, Florida, Georgia, and Mississippi. This year, over half of the country's children under the age of 18 will be people of color. Our current healthcare system is not up for the job of building and maintaining racial equity. Now is the time for Medicare for all. Thank you.
Thank you very much to all of the panelists. We said we were going to go for an hour, but we're going to go for another 15 minutes. We have 4 members on. We have Representative Jan Schakowsky, and Congressman Jerry Nadler, Jamie Raskin, and Suzanne Bonamici was on. I know she really wanted to do this, but Jan, Jerry, Jamie, if any of you would like to ask a question, Jan, why don't you go first and do it? And if we can try to give about each of you 3 or 4 minutes so that everybody has a chance to ask a question. Thanks, Jan. Good to see you.
Thanks to all of you. Thank you, Pramila, and thank you, Debbie, for putting this together. Excellent, excellent panel. I want to thank all of you. I want to ask a question of our sister from Canada, Professor Palmer. I wanted to just talk to you a little bit about, do you see any of these kinds of racial and ethnic disparities in the occasion of getting the virus? Is that solved by having universal coverage? Let me see if she's still on. And
yeah, I see her.
I'm unmuted. I'm unmuted.
Okay.
Yes, there is still some disparity. I mean, hospital and physician care in Canada is available to everyone who lives here. So regardless of race, regardless of ethnicity, income, gender, sexual orientation. So we all access the same healthcare system in our home provinces, and you can't actually buy hospital or physician care just because you can afford it otherwise. But that said, single payer doesn't fix everything. So there are transportation barriers to getting care. There's language barriers. There are still disparities in health related to the social determinants of health. There's still differences in things like access to income and food security and affordable housing. And we certainly have disparities in our rural and most remote communities. There is a strong association between COVID incidents and low income and conditions of work and conditions of housing and visible minority status and low levels of education, all those things. And there are certainly ongoing efforts to address all of that, but at least we all have Medicare for all. And that gives us a fighting chance at addressing these determinants. I'll just add that I have heard people say that Canada is a racially homogenous country, so it's easier for us to have Medicare for all here. But Canada is actually a racially, ethnically, and culturally diverse country. It is a myth to think that we are all white here. About 73% of us are white compared to 72% in the United States. And the rest of us are a combination of Aboriginal and South Asian and Chinese and Black and Latin American. I think we have the same kind of diversity here that you have there. Yet the common thing that we have here is access to publicly funded healthcare for hospital and physician services for everybody, regardless of any of our racial differences. I think that health is the starting point for our human potential as human beings and as nations. And I think that without equitable access to healthcare, we can't optimize health. It underpins everything.
Yeah, I'd be interested if there are any numbers. I can't imagine that you have in Chicago, you heard 30% African Americans, 70% of the deaths among African Americans. So it would be interesting to see. I've got to think that universal coverage and access to healthcare does diminish at least some of the inequities.
Yeah, for
yeah.
sure. Yeah,
Okay.
because there's no barrier to seeking care.
Right.
You know,
Right.
anybody can go, anybody can get care.
Thank you so much.
You're welcome. Thank you for the question.
Jen, can I ask a question? It's Jamie Raskin.
Me?
Oh, I
Yeah,
forgot. I
Jamie-
was
Jamie,
talking
go
too,
ahead.
and I wasn't.
Okay.
Go.
Hey, first of all, thank you so much, Debbie and Pramila, for organizing this amazing panel. It's you know, I spent all day on Zoom, and this is the best panel I've seen in months. Okay. Two questions. One, are the panelists available to come and speak on to my constituents if I do a town hall meeting about Medicare for all and the crisis? So I wonder if they'd be willing to.
Amy, we're happy to pass along people's information, assuming everyone is okay with that. I'm sure
Great.
people would love to
They're
do
all
that.
giving you thumbs up.
Here's my other question. You know, this is a moment of profound crisis and danger for our democracy, for our people, in terms of health, in terms of environment, in terms of elections and democratic accountability and so on. But as we've seen from the protests in the street, it's a moment of boundless opportunity and open thinking about problems. And so the public is ready for sweeping structural changes. And I'm just wondering if any of the panelists want to comment on how we take their insights about the systemic nature of the health crisis we're in as exposed by COVID-19 and translate that into a reinvigorated mass movement for healthcare for all.
Any one of you want to take that on?
Hey, this is Eagan Kemp with Public Citizen again. Yeah, I think this is a crucial time for people to be telling their stories. I can tell you one of the most powerful stories in the 15 years that I've been working on the Hill on health policy was actually Representative Raskin's. He was on a telepresser and he talked about his health experience. And that really, it shook up some people because it's such a powerful thing when you tell your story and you highlight the struggles that you've had. Because as Americans, we've all struggled with healthcare. We've all been on, you know, a high deductible plan. We've all missed, an appointment we should have had. We all didn't fill that prescription or started cutting pills in half. And that's a reality that when I talk to people around the world, they just don't understand. They can't fathom that. And so reinvigorating it by have everyone tell the stories. I know it's hard. I know it's sometimes scary, but you're really putting yourself out there and helping other people tell their stories. And that's how we build the movement.
Any of the other panelists want to?
Yeah, Pramila?
I-
Pramila?
Hang on one second, Jerry. I think Jean was about to say something and then we'll go to Jerry Nadler.
Thanks. I just wanted to add that I think that's part of what we're doing here with this virtual meeting that you've set up so that we do continue to get the word out, especially to the people who can most help. But I also want to point out that Ms. Raskin is right. If we do not use this moment right now, this profound opportunity, as he put it, what you will see is the corporations and the employers putting together and using what they have learned. So for example, they have learned you don't necessarily have to have a nurse right there with you. You can do it on a screen. You don't need to go to see a doctor. You can do it on a screen. If we don't use the opportunities now to show why we need Medicare for all, how it's hurting all of us, how it could help all of us, we will be left with their using their opportunity to make things worse.
Thanks so much, Jean. And Jerry, we'll give you the last.
Well, thank you. This has been a wonderful discussion and about the impact of the virus and the pandemic on a society without universal health care and a society without Medicare for all. And it's obvious what we have to do. I just want to comment on an allied topic. During the political campaign earlier this year, one of the objections that was voiced to Medicare for all was, by those who opposed it, was how are we going to pay for it? How are we going to pay for it? We're going to have to raise taxes and all. And yet it is so clear that, and I don't understand why we didn't point this out enough, and we must in the future. The entire mechanism, $500 billion a year of private insurance, and not only the money for the profits, but the money for the market segmenting, the money for the entire administration, that all the insurance companies do, the money that all the hospitals and the doctors have to spend to deal with the bureaucracy of the insurance companies. It's $500 billion a year, all of which could be spent on medical care instead of being spent on either profits or just administrative costs. It's a huge amount of money, and we could institute a Medicare for all system without increasing taxes. I mean, that's not a discussion we have to get into, because the cost savings from just eliminating the private insurance leech on the system would pay for all of Medicare for all the services, everything we're talking about. And when we get to debating this on a political level again, we ought to be emphasizing that.
Thank you, Jerry. Does any of the panelists want to comment on that? We had a number of questions around costs that we didn't get to, but Dr. Sriram, I see you wanting to respond. You're on mute.
Yeah, I totally agree with Congressman Nadler's assessment. It's tragic that we never question the line items of how much we must apparently pay hospital CEOs, how much we must pay pharmaceutical company CEOs, health insurance industry CEOs. Those are line items that apparently our status quo has determined to be essential to the functioning or dysfunction of our healthcare system. To me, one of the other costs that I think that we don't talk about enough is that how much potential of people are we losing by having them stuck in jobs that they don't want to be in because they are scared about losing their health insurance? How much potential are we losing from people who would actually be building better lives for themselves if they if they bet on themselves, if they went and did that vocational program, if they took on some extra education? And yeah, that might mean that they work a little bit less, or that they hustle a little bit more in the jobs that they have. But right now, people don't bet on themselves because they're worried about losing whatever little bit of health insurance they have. And to me, that is a loss for all of our country, when people aren't willing to take that chance on themselves, regardless of what they look like or who they love or where they're from. And I think that is a potential that we don't talk about enough. And it's tough to put it in dollar terms, but it is very much an American value that Medicare for All would, I think, celebrate.
Thank you. I want to give Barbara and then Aaron a chance to respond on both of these as well. So Barbara, we'll go to you next.
Sure, thank you. I really just want to point out that budgets are moral documents, and where we put our money in this country reflects what we value. And so when we ask about what's the cost of a single payer system, every moment spent on that discussion is not spent on why does the current system cost so much? How are we wasting our current money? Why are we spending so much money on wars that we never ask how much cost going into them? Why is it that we don't ask how much money are we giving up at a 15% capital gains taxes for the wealthiest people in America? Why is it that we don't ask these questions? And so I would like to see us have a discussion. If people want to have a discussion about how much single payer will cost, let's have a discussion about what everything in our community costs and put our moral values to those line items. That's the conversation I think we should have.
Beautifully said. Aaron?
Yeah, and I just wanted to jump in on Representative Nadler's point about costs and premiums and taxes and say that, we don't have to think about this in the abstract. We have a great example with a lot of different state houses passing paid family medical leave, where we operate in the DC area. Of course, DC is not a state, but the council passed a paid family medical leave program. And so I can comment on the cost difference between buying something on the private market versus going through a public insurance program. I offered short-term disability insurance to all my staff members. We paid 100% of the cost. And starting next month, we're going to be moving to DC's public system. It's a third of the cost. My taxes are a third of the cost of the private premiums I was paying, and the coverage is better. So I think that's a really great example that I think will let us talk about this issue in a really defined way, because there's already a great example of moving from a private insurance system to a public insurance system.
Aaron, you're such a great example of a high road employer, and we're so fortunate to have you and to have all of the panelists. Debbie and I are very grateful to all of you. I think what we've realized with this, as we've been texting back and forth, the two of us, is that this was an incredibly well-attended panel with a lot of great questions in the chat that we never got to, and a phenomenal group of panelists. And so what we are going to commit to you to doing, to everyone on the chat, is we will schedule these every 2 weeks, and we will be able to dive into these topics with fewer panelists so that we can get to some of the questions in the chat. And our next one, Professor Palmer, you'll be happy to know, is we want to focus on what other countries have been doing and really look at this, because I think we're often told here in the United States that we're thinking too big, that it's too unachievable, that it's not possible. And yet we look at what other countries are doing, even in the time of COVID, where you know, we have really pushed hard to get everything from My Paycheck Recovery Act included, where the federal government would subsidize paychecks and health insurance, to, you know, getting insurance covered for anybody that seeks care at the point of care. So we will continue to do this. I want to thank you all so much on behalf of both Debbie and I for your tremendous leadership as professionals in your respective fields, and to say to everybody that has tuned in today that we are grateful for you continuing to push. There is no great change that has ever come about in this country or in the world without a movement pushing for it. And so we're very grateful to everyone that has tuned in, and please stay tuned. We will be doing another one of these in 2 weeks. We're hoping to focus on international, as I said, but then we want to get to the cost question. There are a number of other things we've explored here. Aaron, we'd love to work with other high road employers, with you and Marty, who I realized I didn't give, I think he had to hop off. So, oh no, he's still there. Marty, I realize I didn't give you a chance because I don't see your picture here, but I want to thank the machinists for just their tremendous leadership on this issue and others. When people say labor unions don't want Medicare for all, I think we are in a really transition time where people are seeing that not only have you had to use your collective bargaining power to bargain benefits, but also that this is what happens when it's tied to a job. So we are looking forward to all of you being a part of this next one that we do in 2 weeks. Thank you so much on behalf of the Medicare for All Caucus. Thank you to our members who have participated, and let's keep fighting, people. We've got a big road to climb, but we are capable. Thanks so much. Take care. Bye-bye.